E-Club of Melbourne for Saturday the 16th of May 2020. And tonight we're bringing to you a very special event. We're bringing you an event on complex decision-making during COVID-19 with Dr. Stephen Warrillow from Austin Health. So we're going to have a bit of an interesting meeting tonight. We're going to be running this in a little bit of an unusual way. We're going to have this running both through a Facebook live stream and also through Zoom. So for anyone who's on our Zoom call, you might notice that you're muted at the moment. If you have any questions or anything you would like to ask as part of this, please feel free to drop them in chat and we'll be jumping into questions at the end. Likewise, for anyone who's joining us from Facebook Live, please feel free to drop comments onto the video. We'll be looking at those for questions as well. So thank you very much for joining us. We're very happy to have you here with us tonight. And I'll just start off with a quick acknowledgement of traditional owners that we're meeting tonight on the lands of the Indigenous people of Australia. And so in Melbourne, that would be the lands of the Wathaurong people and the Wurundjeri people, who are the traditional custodians of the land, and we pay our respects to elders past, present, and emerging. And so to kick this off tonight, we're going to have our club president, Madhu, give a little bit of an introduction for the evening and give us something to go on with. So Madhu, I'll pass this over to you and we can kick this off.
Thank you, Stephen. Welcome everyone to our ethics forum. This is the first kind of a meeting that we are having tonight, and I really look forward to hearing from Dr. Stephen Warrillow, and I welcome all of you all who from whichever club, Rotary Club you all are amongst us, and non-Rotarians. So just enjoy the evening. And our vocational service chair, Angelica Marotta, she lives in Tuscany in Italy. So due to some prior engagement, she couldn't be present tonight. But we have been working very hard from the very beginning. It was her idea of this kind of a program, and she really started from the very beginning, helping us as to how we should go about it. So though we are missing her, but we do understand that she has some work engagement tonight. So over to Stephen, and welcome everyone.
Thank you very much, President Madhu. So we'll get into the evening fairly quickly. And so to do that, I'll introduce the person who's going to be interviewing Dr. Warrillow this evening, and that will be past President Belinda Greaves, who's joining us tonight from Brisbane in Queensland. So welcome, Belinda, and I'll pass this over to you.
Thank you very much, Stephen. Thank you everyone for being here. It's great to see so many lovely faces. I'm not Lee Sales, let me put it out there, but I'm very happy and willing to be the person to ask the questions this evening to Dr. Stephen Warrillow. As Stephen, our Stephen has mentioned already, if I don't cover something in my questions that you would like to know more about, please feel free to drop that question or at least make yourself known in our chat so that we can do that at the end with some further questions to Dr. Stephen. So Stephen, I'm just going to begin by introducing you with a short bio that you've sent through for us. So I'm going to read this, everyone. Dr. Stephen Warrillow is a critical care physician and Director of Intensive Care at Austin Health. Stephen's training pathway has progressed through internal medicine and intensive care in Melbourne, regional Victoria and the United Kingdom. He's immediate past president of the Australian and New Zealand Intensive Care Society and director of the Critical Care Institute at Epworth Healthcare. Professional roles have included aeromedical retrieval physician. I apologise if I make any errors with my pronunciation tonight. I will do my best. Helicopter and fixed wing, research ethics committee chair at Austin Health, convener of the 2019 World Congress of Intensive Care, and senior lecturer and research fellow at the University of Melbourne. Stephen is a medical educator and examiner for the University of Melbourne, the College of Intensive Care and the Royal Australasian College of Physicians. He's also an active academic with 86 publications, numerous international conference presentations, and has completed a PhD in intensive care research with the University of Melbourne. Outside of medicine and academia, Stephen is a keen cyclist, bushwalker, cross-country skier, and holds an advanced amateur radio operator licence. Have we got time for questions now? I think that's quite a bio, so thanks for sending that through. Stephen, I'm just going to start off, you know, this might seem really obvious to a few people, but it's good to get clarification about lots of things. So can we just start off by asking you, what is critical illness? Can we start off with that?
Thanks, Belinda, and thanks, Rotary, for the opportunity to be part of this evening's events. So critical illness is where a person becomes extremely unwell. There's a range of potential causes. It could be major trauma, such as a car accident. It could be a serious infection, such as pneumonia. It could be things like poisonings or drug overdoses, those sorts of things that cause a person to become very, very unwell, such that organ systems start to fail. So they may be unable to breathe themselves. The circulation may not be able to maintain enough blood circulating, or the heart function to maintain an effective circulation. You can have liver failure, the kidneys might stop working. And many of my patients in intensive care develop what we term multiple organ failure, which is really kind of what it sounds like, where multiple organ systems, so the lungs, the heart, the kidneys, the liver, the circulation, the clotting, brain function, all start to fall in a heap, really. And that's a life-threatening situation, which if we don't intervene, that person will succumb to their overwhelming illness.
Mm-hmm. And so specifically, let's talk about intensive care and intensive care unit. What is that?
So intensive cares were invented about 50 years ago. They started after the great polio epidemics that went through Scandinavia, where it was realised that you could massively reduce mortality in people who, for example, couldn't breathe because of polio by getting teams of medical students to ventilate them very crudely, just using literally their hands to squeeze airbags. And from that idea, and also post-operative care, grew the concept of having a geographically distinct area within a hospital, a specific ward which had specifically trained specialists, so specialist doctors with advanced skills in resuscitation and organ support, but also, just as importantly, nurses and physiotherapists and pharmacists and other allied health professionals with very advanced skills required to maintain organ function. And it's an area where you can do things that you can't do in any other part of the hospital. So you can have people on mechanical ventilators. You can have them on hemodialysis machines, not just for 4 or 5 hours, but continuously for days at a time. You can run complicated, very difficult to manage infusions that you can't really manage anywhere else in the hospital. So it's really the high end, the pointy end of acute care medicine, where we really only look after the sickest of the sick. These are people who would be likely to die if they weren't supported with, say, organ supports in the intensive care unit.
Okay, so obviously this discussion tonight, we're going to be focusing on ethics and ethical decision making, which you know, a lot of people face in their lives, but this critical decision making that happens within an intensive care unit is perhaps something that many people aren't familiar with. We can't ignore Covid19 and the role that that's currently playing in the world. It's everywhere, and it's turned the world upside down. It's been a substantial impact for most of us. We'll go into a bit more details about that. Can you tell us a little bit more about yourself and your role within intensive care?
So I'm the Director of Intensive Care at Austin Health. We run 29 ICU beds and also work in private practice in intensive care at Epworth Healthcare and Epworth Eastern in Box Hill. Mm-hmm. My role as an intensive care specialist is to lead a team of healthcare professionals that includes medical staff, senior doctors such as myself, but also people training in intensive care medicine, emergency medicine and anaesthesia. So we have multiple people working with us to gain skills and experience. A highly skilled nursing team. So these are nurses who've done additional training and certification beyond general ward nursing, as well as physiotherapists and pharmacists and the like. And intensive care is very team-based. So we get patients that we know are coming that might have major surgery, such as open heart surgery or complex brain surgery, and they might need only a couple of days of post-operative support in an ICU. We also have patients that deteriorate on general wards. So someone is admitted to a ward but then becomes more unwell or unstable and has to come to the ICU. And also patients that come from the emergency department. So people who might have a cardiac arrest outside of hospital, or get an overwhelming infection such as meningococcal disease or similar, or COVID-19 as it turns out, from the community, who come in and their needs exceed what a general ward can manage. And so when we bring them into the ICU, we rapidly assess them. We try and get the story, what's actually happened to this person, because that's incredibly valuable to understand what's been going on. We clinically assess them, just like anywhere in medicine. We actually feel their pulse, we look at their eyes, we listen to their lungs, we examine their abdomen, all the fundamentals. And then we, in concert with that, we institute organ support. So if they can't breathe for themselves, we'll put a breathing tube down into their windpipe and put them on a ventilator. If the circulation can't cope on its own, we'll start infusions of medicines like adrenaline by infusion. Or we can even put them on a heart-lung machine, which is sort of the ultimate in life support, where we can entirely take over the role of the heart and the lungs for a period of time. If their kidneys have stopped working, we can put them on a dialysis machine. So it's a lot of different organ supports, as well as things like antibiotics and fluids and blood transfusions and those sorts of things. And what we're trying to do is to treat the underlying disease. If it's an infection, we will treat it with antibiotics. But we're also trying to keep the person alive for long enough for them to start to respond to the problem themselves. A lot of what we do is really preventing death for long enough, we hope, such that the person has the opportunity to recover.
Okay, good. All right. So as an ICU doctor, what are some, prior to COVID-19, what would be some of the common ethical issues that you encounter?
Sure. So one of the challenges is that we know in Australia we have very good outcomes from intensive care and they keep getting better all the time, but not everyone will survive a critical illness. And all of the treatments that we administer in the ICU are somewhat burdensome for patients. Being critically ill involves a degree of suffering. Now, we work very, very hard to mitigate that by controlling pain and anxiety and using sedatives as required so that the person isn't frightened. We seek very much to very proactively manage things like pain. But being critically ill and hooked up to multiple machines is not pleasant. It's pretty challenging for patients and for their families to witness. And all of that is absolutely justifiable when we know there's going to be a good outcome. So I'm very prepared to put my patients through a very challenging period as part of their care when I know that it will totally be worth it, that they'll survive and have a really good functional outcome and get back to living their life again and be with their loved ones and return to work and all that sort of thing. And that's our goal, obviously. However, for some of my patients, either their critical illness is so overwhelming or they've got underlying chronic health problems that mean they may or may not survive no matter how hard I treat them. And if we knew who was going to survive and who definitely wouldn't survive regardless of treatment early on or at the presentation, that would make the decision-making relatively straightforward. But life's more complicated than that. And it's often difficult to tell, even when you're very experienced and you've got all of the test results and a lot of expertise. It's not always possible, or in fact, it's commonly not possible to know what the outcome is going to be for that person. Now, we always err on the side of treating pretty aggressively, in fact, very aggressively, if we think there's a chance. But we know that sometimes it becomes apparent during the course of treatment in the ICU that the treatments aren't working and that the person deteriorates despite our care, or we stop them from dying, we pull them back from the brink, but that the treatment doesn't actually make them well again. And they're sort of stuck on multiple organ supports like mechanical ventilators and dialysis machines and infusions, and yet they're never going to actually recover. And the last thing that we want to do is, however well-intentioned, is to inadvertently prolong someone's suffering when the outcome is that they will die no matter what it is that we do. That's not fair to that person to inflict the burdensome treatments that we provide if we discover actually over the course of time that they're not going to make it. And that's a tough call. And the last thing any doctor wants to do with any family or patient is have a conversation where you take away all hope. That's not what we started, training medicine to do. And yet it's one of the most important parts of my role is to recognise that the diagnosis might actually be dying, and that my treatments aren't going to allow survival, but they will make dying take longer. And that's not a diagnosis that you really want to make. It's not a diagnosis that you just make in haste or impulsively. It's something that usually emerges over time, often many days. And we consult with families frequently, who we really try and keep at the bedside as much as possible to have them engaged in our assessments and the patient care. Mm-hmm. And to also to understand from the families, because these patients are often too unwell to speak for themselves, to find out for that unique human being, because we're all different, what are their values? What would they want their outcome to be? And if you ask 100 people, you get 100 different answers. But what we're trying to do is, if we know that survival isn't possible despite everything that we've tried, to ensure that we're not unnecessarily or inappropriately prolonging a life that the person would not have wanted if we could speak to them, if they could share their insights with us. Mm. And that's a tough balance, because ethically we want to give everyone the best chance that they possibly can to survive, but we also ethically don't wish to subject them to treatment that they might not want if they knew that the outcome was going to be very poor, or that they would die no matter what it is that we tried. And at any given time in my unit, there will be a couple of patients like that. And it's often easier when I look back to see the sequence of events to pick it and think, oh, actually it was kind of now in retrospect, it was obvious a few days ago. The problem is it's not obvious at the time. Mm. So that would be a common scenario where we're trying to get the balance of how aggressively we treat someone without crossing a line into treatment that would be non-beneficial, or that they might not even want if they could speak for themselves.
Okay, so let's think about, are there any further ethical challenges that have come up as a result of COVID-19?
Sure. So that's a great question. And I can think of two that are quite different to our usual practice. The fundamental ethical principles and training that intensive care specialists apply in their normal practice absolutely apply in COVID. There's no new ethical paradigm as such. This is really, in many respects, part of an extension of our normal professional role. But there are two elements that are somewhat different. One of them is, Australia, fortunately, has a pretty well-resourced intensive care system by global standards. We are fortunate. We are a wealthy country. We've got well-trained nurses, doctors, and the whole team. And whilst we'd always like a few more beds, in terms of the number of beds that we have for business as usual, we're pretty good. We've got a pretty good match between demand and supply. Now, one of the challenges, as we've seen from New York or the United Kingdom or Northern Italy, is that when you have a global viral pandemic, such as COVID-19, there is the very real situation where demand can completely overwhelm available resources. And certainly some of the modelling that we looked at early on when COVID was first arriving in Australia, and these are very credible models, predicted demand that would exceed capacity by more than 500%. So we were very concerned that we would see scenarios such as we absolutely witnessed from our good friends and colleagues in Northern Italy and the UK and New York and those sorts of areas, where there was simply many times more patients who might benefit from intensive care. These are people who might survive, than there were ICU beds, ICU nurses, ICU doctors and ventilators. And that's not a scenario that we normally encounter in Australian intensive care practice, where we're often tight for beds, but it's really not on an individual patient decision-making scenario, it's not about the resources really ever. If I think the patient will benefit, or even if I'm not sure, but I want to give them a good run, I can really always make a bed and find a nurse and get the ventilator. I can almost always do that. Whereas we were staring down a scenario where, for the first time in our professional careers, we might have had 5, 6 or 10 patients, all of whom might be eligible, might genuinely benefit, and only one ventilator. And that's something that we haven't encountered before. And I think that's been a cause of huge moral distress for my colleagues who work in areas that have been overwhelmed, where they similarly have had to make choices that they'd never had to make before. Now, my friends and colleagues that work in the developing world and resource limited countries, they do this every day. And it's an exercise in humility to go and work and visit with colleagues who work in developing countries where they have to make daily decisions about who gets the one ventilator they've got left. So it's a real reminder to those of us work in well-off countries and well-resourced systems how protected we are from such difficult choices. And the second difference is that up until about 10 years ago, intensive care was a pretty isolated part of medicine. We were locked away from the rest of the hospital. We had very limited access from families. We would sort of kick relatives out before the ward round. And it seemed like the right thing to do at the time, but in retrospect, it was clearly a terrible thing to do. And in the last 10 years, we've really embraced the idea of having families and loved ones at the bedside as much as possible. For many obvious reasons. Firstly, they want to be there. Patients want them to be there. And as doctors and nurses, we learn an awful lot from families. We can ask them questions about their loved one. We can ask them about what their loved one's goals would be. We can ask them about tell us the story about how they became unwell. Tell us the history of events that led to them to this point. And you always learn something. And it saves us time because instead of the families having to catch up with this later on, we can update them, in real time. And also, I think it's a very important opportunity for families to see us practicing our craft and seeing the care that's delivered, and such that if we have to have what is really an awful conversation that we can't save their loved one's life, they already know because they've been there. They've seen us trying so hard. They've seen us doing our clinical assessments. They've seen the nurses holding the loved one's hand, and they see the care, such that if we ever have to have the conversation that no one wants to have, they've got trust in us because they know that they've seen us try everything, and they're not blindsided. They know what's coming because we've been having those conversations all the time. Now, COVID-19 has turned that on its head, and we have had really no visitors in Australian intensive care units, except for those patients who are absolutely dying. And even then, it's been incredibly restricted. And I have to say that's been a pretty dreadful experience for patients. It's been awful for relatives, and it's been jarring for us as doctors and nurses because we've become very used to having families around and we really like it. And it makes us better at what we do. And it seems very strange, and your heart really breaks sometimes when, for good reasons, to keep everybody safe, including the patient, we've not been able to have access from relatives except in a very limited and strict sense. And that's been horrible.
Yeah, it must be heartbreaking. So we are fortunate in that we haven't got to that situation where the demand has far exceeded what we can supply in terms of the care. Obviously, I would assume that in the lead up to all this, when there was that risk that was going to become the case, I would imagine that there was a discussion and thought by you and your colleagues about how you would prioritise the patients that were receiving treatment at that time. So what kind of factors would determine the priorities of the patients that are receiving treatment?
So as you might imagine, this has been an enormously complex process because we're not out of the woods yet. I think we have dodged a bullet, and in Australia and New Zealand, we are unlikely to be overwhelmed. So that's great. And congratulations to the community, because who knew that Australians would be so graciously cooperative and obedient? It's remarkable.
For the most part, yeah.
For the most part, it's been incredibly successful. So we are best in class at a global level. Australians have done remarkably well. So in addition to planning like fury and working sort of 18-hour days for weeks at a time to prepare, we prepared it in my hospital for 4 or 5 times business as usual capacity. So we implemented that. But we also recognised that we did need to perhaps codify our thinking and be very transparent in how we would approach the scenario where we couldn't treat everybody. And the manner in which we approached this was really an extension of our usual practice, whereby we took the view that we would not set out to exclude certain groups of patients, that we would not do it that way, that we would avoid essentially the idea of criteria, which sounds superficially like an attractive approach. Well, we'll just have, you're going to meet these criteria and you'll be in or out based on the criteria. And obviously we were very keen to make sure that we didn't have any sense of a deliberate or, just as importantly, non-deliberate discrimination. So the way we approached it was to really have a process of prioritisation, that if you weren't critically ill and didn't need intensive care, we wouldn't admit you. And that might sound kind of obvious, but it's nonetheless worth stating. So we would only manage people in ICU that actually needed intensive care. We then took the view that if someone was so sick when they came in that it was obvious that they were dying no matter what we did, and there would be no benefit of admitting them, then that person who wouldn't benefit wouldn't come to intensive care because they were so unwell, their illness was so overwhelming, and they were not going to benefit, and we were very confident. Then we would make that person comfortable, they would be cared for, but wouldn't be admitted to an intensive care unit. And then we took the view that if your illness was such that you had a chance of responding and we thought you had a reasonable chance of surviving intensive care, that was the sort of person we would admit. And also we would take into account how likely was this person to survive after intensive care. So someone who was likely to die but we could get them through and was then going to live for 50 years afterwards, that's a pretty good run, and we would be very keen to admit someone like that to intensive care. Whereas if someone might survive but then might only live, say, 18 months afterwards because they had advanced cancer or because they were very, very frail from a nursing home, then that person would have a very short predicted life after a critical illness. It's not that we would say they were excluded, but we would prioritise them lower than the person that would live 50 years. We also took into account how many life stages had this person lived through. And it seems adjusting that a person who hasn't lived through as many life stages would be given the chance to live through as many life stages as possible. And what that really means is that younger people, to be blunt, would be offered intensive care ahead of older people. And that's not to suggest that older people are excluded. If we've got enough beds, we will absolutely admit older patients. But if it comes down to 2 people and 1 ventilator, then the person who's lived through less life stages would be given the opportunity, because it seems just to give them the same chances that the person who's lived through more life stages has also had. Mm-hmm. So those are the key things. And we also made it very clear that it wouldn't be based on things like religion or race or gender or political affiliations or any of those kinds of irrelevant considerations. We would never obviously take that into the decision-making process.
Mm-hmm. Okay, so within the team that you work in the hospital, who is making these clinical decisions, and what happens if there's conflict and disagreements?
Doctors disagreeing? Unheard of. So this happens in intensive care as part of our normal professional roles. Mm-hmm. So it's always a senior intensive care specialist. So these are people that have done between 13 and 18 years of training. So they've got a lot of experience. And they, as an intensive care specialist, you get very, very good at figuring out what the person's likely prognosis is going to be. And we've got actually pretty good evidence from large studies that intensive care specialists are rather good at that. As it turns out, they're better than the scoring systems, pretty much. So we do have illness severity scoring systems. And they have value, but they're not used to guide clinical decision-making. They're used to guide resource planning, or how many beds do we need for a population. They're not used to guide individual patient care. So it's an intensive care specialist who will take a full history from the patient and their family, will assess them head to toe, We'll look at their x-rays, look at their blood tests, we'll look at their ultrasounds, their CTs. We'll talk to the other specialists involved in the care, so there will almost always be other, in fact, there are always other specialists. So there might be a ranger, there might be a neurosurgeon or a cardiac surgeon, there might be a hematologist or infectious diseases specialist. So we always consult with our colleagues. And then the intensivists will figure out what is the way forward and will share their thinking with those other specialists. Mm-hmm. And we seek very much to get a consensus opinion and with as much certainty as we can get. And sometimes if it's not clear or someone says, look, I'm really not sure yet, we'll say, let's wait a bit. One of our best prognostic tools is time. And so if the cardiac surgeon says, look, I'm not sure, I'd like to see how things go for another day or so, as an intensive care specialist, my answer is absolutely. I might be pretty convinced that things will go badly, but unless I've got my colleague on the same page, I shouldn't be a lone ranger and go out on a limb here. It's really important to get a real clear consensus. And all the while, we're talking to families the whole time. And a family should never hear for the first time that things are going badly wrong when the patient's actually dying. They need to be brought along on the journey, such that if we do have that conversation, we're saying, look, we're terribly sorry, we have tried everything and we've consulted with all of our specialist colleagues and we've come back to the bedside repeatedly and we've tried every test just to make sure we're not missing anything. And we're so sorry, but we can't get your loved one through this. They kind of already know, and then you're not telling them something that they haven't figured out for themselves. And that model is termed sort of shared decision-making, where we would never say to a family, look, it looks pretty bad, do you want your loved one to live or die? Mm-hmm. Because it's a terrible question and it's a nonsense question. Families want their loved ones to live. Mm-hmm. So do the doctors. We want the patient to live. It's really, we're saying to the families, there is nothing else that we can do that will help here. And we're so sorry, but your loved one is going to die and the treatments are only going to make that take longer. And families, when we've done our job well and done the communication part well, they know it's coming. When we have that meeting, it's really part of what they're expecting to hear already. It's the last thing they want to hear, but they know it's coming. And even when we then have a consensus between the medical team and the family that we're changing our goals of care, we might withdraw treatments, but we never withdraw care. So the care continues. And the goals of care will go from saving the person's life at any cost to making sure that their pain is well controlled, that we don't do things that will compromise their dignity, that we don't do things that will make dying take longer than it all otherwise would, or that we don't do things that would keep family away from the bedside. So that, and if the family, look, it doesn't happen often, but sometimes families will disagree and they'll say, oh, look, it's not that we don't trust you, but we just don't, we see it differently. And that's okay. We would then say, we can appreciate that this is really hard for you. I never say I know how you feel because I don't. It's not my loved one. But we can certainly appreciate, and I'll say things like, look, you are not the first family to find this difficult. Why don't we catch up again tomorrow? Let's leave things as they are. We'll continue caring for your loved ones, spend some time at the bedside, and let's catch up in a day, or let's catch up tonight. And I think it's really important to families in particular never to feel rushed or that there's any agenda beyond looking after their loved one, and that you are there to provide advice and support, but also you're not leaving them solely having to make the decision, because one really important thing that we don't wish to inflict upon families is the risk of them feeling guilty that they decided whether their loved one lived or died, which is a nonsense. They didn't decide. The disease is what caused their loved one's death, not the doctors or the family. And that really this is a medical recommendation that we should withdraw treatment. But we can see that you need some time, so you can have the time. We are not going to rush this. We are not going to bulldozer through a decision that you are grappling with. And it's almost always the way when families have that time and space, they'll usually come to us before 24 hours and say, actually, having spent more time at the bedside and thinking about what you've said, and seeing what you've done and feeling that you let us be part of the decision, we're okay with it, even though it's not what we wanted or it's not what we hoped for. We can see that you're right.
And so with COVID-19, how is that communication with the families differing?
It's so much harder.
Yeah.
So as I touched on earlier, families are normally at the bedside, particularly if someone's really very unwell, and especially really always when they're doing very badly. The families are there, you know, often sort of 16 hours a day. We send them out for breaks because it's exhausting. Having a loved one critically ill in ICU is emotionally and physically exhausting for people. So we make sure that they do some self-care as well, but they'll spend a lot of time there, and we're talking to them constantly. But in ICU, there's a nurse there 24 hours of every day. So the families can ask any question, seek clarification, do whatever they need to do to understand. And as a doctor, I might talk to them 3 or 4 times a day, by either informally or in a scheduled meeting. So with COVID-19, that's made all that extraordinarily difficult. When it is recognised by us that we're at the end of life, we do allow, under strict circumstances, a couple of family members in. But again, it's not what we normally do. I've had families, you know, in some cultures, your family is up to 36 people. It can be cousins and nieces and nephews, and I've had, you know, 40 people in a family meeting. The family is whatever they define themselves as. And so that's absolutely fine. And so saying you can have 2 people, that's tough.
Yeah.
So that's made things very challenging for us as the professionals and also for families. We have used things like video conferencing. We've used phone calls. So all of those things have been helpful, and they're way better than nothing, but I don't think any of us can pretend it's a substitute for actually holding a loved one's hand or being physically present. The other thing we've done is we've got very good relations, very long-standing relations with our colleagues in palliative care. It might sound strange that intensive care has a lot of synergy with palliative care, but actually we do. We're philosophically very much aligned in our approach to suffering and providing good quality end-of-life care and ensuring that we don't do things that we don't need to do and would be against the wishes of a patient or their family. And our palliative care colleagues have been absolutely wonderful in stepping up, and we've had a number of patients who have been dying that we've managed to actually transfer to the palliative care unit where they have less restrictive visiting, so that we can have additional family members present at the last couple of hours of life. And so we're very grateful for their support, because otherwise it was always terrible for people, but it would have been way worse than was otherwise the case. So, and families have been incredibly gracious about it. I've often reflected, how would I feel if this was my loved one? And I think I'd be angry, and that this was incredibly unfair. Not angry at the staff. I'd like to think I wouldn't be angry at them, but just angry at COVID, angry at the universe. And people have been remarkably measured and gracious, and they've said things like to the doctors and the nurses, "Are you okay?" We're saying, "Well, thanks for asking. We're okay, but my goodness, are you okay?" People have been really remarkably resilient and understanding under just dreadful circumstances. It's been an exercise in humility and quite inspiring, I must say.
Thank you. There's been some amazing answers there. It's a bit emotional, to be honest. I had a couple more questions, but I actually, I've recognised that there are a couple of guests here today and people along at the meeting here who have some questions that relate to what you've also been talking about now. So I'm actually thinking now to our Stephen, it might be a good opportunity now to open up to a few of the other people who had some questions, particularly in relation to COVID-19 and how that's affecting your decision making. So Stephen, would that Stephen, both Stephens, would that be okay if we open that up just now?
Yep, fine by me.
Sure thing. So there were two questions that have come through so far. Actually, a third one's just come through. One of these is just touching on your point around the involvement of families and their role in things. And that is, what is the role and legality of advanced care directives, and can next of kin ignore or override these?
Great question. So it varies from jurisdiction to jurisdiction. So I have to, I'm most familiar with what happens in Victoria, where I work in Melbourne. The themes are similar through other states and territories in Australia, but they're not exactly the same. So people are encouraged to talk to their families about what their wishes might be if they were critically ill and couldn't speak for themselves. I've certainly done that with my family, that they know what I would want. And that's probably the most important part, to be honest, having the conversation around the kitchen table with a cup of tea when things are good. It's a conversation to have when things are peachy, not when things are terrible. And then there's encouragement for people to document them. And every state and territory will have its own particular legal approach to this. But the principles are that you can basically, as an individual, document in a formal manner what your goals of care would be, what matters to you, such that what a good quality of life would mean to you. So I might say, look, for me, it means being able to go into my garden, being able to enjoy a glass of wine with my family and a meal, being able to listen to good music and that sort of thing. And if I couldn't do that, then I'd be pretty wary about having treatment. But some people, some people might say, look, if I couldn't ski anymore, I wouldn't want to go on. So we're all different. So people can document that. And in some jurisdictions, they can also document what treatments they would or wouldn't want. So people could, for example, document, I wouldn't wish to be on a mechanical ventilator, or I wouldn't wish to be admitted to intensive care for more than a couple of days. But people can do that as well. As an intensive care specialist, I must say it's the first approach that works better, in my opinion, where people tell me what their acceptable outcome is, and that gives me something to work with. Whereas for a layperson to say they do or don't want to be ventilated, well, as a specialist, I know a lot about ventilation, and sometimes I find the decision a bit tricky to make. I think it's very difficult for a layperson to know what is a good or a bad idea in terms of what treatments, because treatments are very complicated, they're very specific, they're situational specific. And even if they talk to their general practitioners are outstanding at general practice. I'd be rubbish. I'd be terrible at general practice, but they're not experts in intensive care. So saying I wouldn't want to be ventilated, my question will be, well, what does ventilation mean to you? And for how long and under what circumstances? So I think writing advanced care directives that talk about the outcome, the functional outcome that a person would want, are extremely helpful to me and a great guide. And I'm very supportive of people. I wish more people did that. Now, in an advanced care directive where you specifically outline what you will and won't have, that is in Victoria at least, and it's different in different jurisdictions, but that is a legally binding document that a loved one or anyone else for that matter can't, strictly speaking, overturn. Now, there's a few little nuances there where there are kind of loopholes for emergencies, and maybe the person changed their mind, or the doctors think actually they didn't really understand what they were signing. And there are rare circumstances where you can work around that. But generally speaking, if someone has got a legally binding, appropriately set out advanced care directive that is very clear and it fits the context that they're talking about, and as a doctor, I'm quite convinced that it kind of stands, then it's pretty difficult for a loved one to overturn that. So I guess it begs the question, well, what do we do then? And the answer is we talk. We talk. We would always prefer to have everyone on the same page than to make a decision that is going to be very challenging or contested by other relatives or family. So we would ask them, can you help us to understand the different perspective that you're bringing, because the document that we've got in front of us seems clear in this regard. What insights can you give us that indicate that you've got a different perspective? And then you kind of have a conversation. And then sometimes people just aren't ready yet. They kind of actually know what should happen. They're just kind of, they're blocking it because they love the person that they care about and they don't want them to die. And if you give them a bit of time and space, they will do what it is that they need to do, which is to honour their loved one's wishes. And that's really what we're trying to do. At the end of the day, my primary obligation is to deliver the care that person would want for themselves. And the way I know that is through their loved ones, their relatives that I can speak to, and any document that they've created. We try really hard to get a consensus. We do not wish to, because at the end of the day, these people will live with this for the rest of their lives. I might think about it a bit as the doctor for a couple of weeks because we're human and it has an impact on us, but not for the rest of my life. It's not my loved one. And then we are affected, but for the relatives, they'll remember it forever, the way that it is managed. So we are very careful to not ride roughshod over people, even if legally we could. It would be a bad idea just to not give people some time and space.
Absolutely, no, and that's a perfect sort of thing there. And I think it comes back to that point of the quality of experience, both for the family and for the patient as well. So, yeah,
I'm on call. Can I quickly take this call?
Absolutely. Absolutely, no problem.
Hello.
And so just for everyone else while this is going on.
Okay, bye. Sorry.
No worries.
That was my lovely mother-in-law. I'm on call, so I thought it might be work, but it was my lovely mother-in-law. She
To be fair, mother-in-laws are also kind of an emergency, so you know.
Oh, don't worry about that. I'll have to, as soon as we're done, I will be calling her straight back.
Brilliant. No, that's really great. And so for anyone else as well, feel free to drop any questions either in Zoom or in our Facebook chat. We'll get to both of those. You made a point there very much about how it impacts yourself as a doctor as well. And so I'll pass over to Belinda, who's got a bit of a question to ask from as well.
Yeah, and this is a question that's come from someone else, but ICU work sounds like very emotional work. There is the added stress, obviously, with COVID-19. So what is or should be done to help manage the staff's stress levels at this time?
So that's a great question. So first and foremost, intensive care, while it does have, as you might imagine, a strong emotional overlay, a lot of it is also kind of routine. So like any job, you get used to a lot of it. That said, there will be from time to time situations which are different and do affect you. Certainly, some families, some patients are more relatable than others and will feel closer to home. And so if I'm looking after someone who's kind of my age, who's got kids my age, you know, it feels different. I'm human. That's normal. And so it does have an impact. And I say to my trainees or colleagues, if you ever have a family meeting where you have to give people the worst news that they're ever going to hear and it doesn't affect you at all, then you should find a new job or take a long holiday. And it's okay if families see that you're a bit affected. In fact, I think it makes you more relatable and demonstrates you care. At the same time, you have to have some professional distance. It's not my loved one. It's not my tragedy. It's not my crisis. So you do have to be careful that you don't fall into the family's grief because it's not your grief. That said, we are affected, and I made a rule for myself very early on as a trainee: never have a family meeting without the bedside nurse for a range of really obvious reasons. And we'll have a chat afterwards, and just touch base and check in. My strongest supports, I think, are my colleagues. So I try not to bring my work home with me, and most of us have found strategies where we do try and keep our personal lives quite separate where you can from your professional lives. There is always an intersection because you can't have two separate selves. You're the same person, but you do try and distinguish between your professional life and your personal life to some degree. And so I've got the benefit of wonderful colleagues at work who I can go into anyone's office, close the door and say, I just need to chat. Yeah, can we have a coffee and have a chat? and I'll just share what it felt like. And I'll say, usually they won't interrupt me or say much. They'll just listen and say, sounds like it was terrible and you did a good job. And it's funny, I think just sharing actually is incredibly helpful. And then we do it with as teams. If we do have a very challenging outcome, if for example, we have a very difficult death in the ICU, so it was particularly a young person, and if it was unexpected, then we will have a formal team debrief. And that will happen several times a year, where we will come together and discuss the case, discuss the impact it had on us at a personal level. And if people need professional support, then that's absolutely available. For the most part, people in ICU, it's like a family. We work together all the time. We're incredibly reliant on one another. And people are mostly going to talk to their friends and colleagues within the unit. And I think that's pretty healthy, because in a sense, they will totally understand. They will completely understand what it is that you're relating in a way which, if you're, there's certainly a role for professional psychologists and the like, but in a sense, you're kind of having to explain to them what happened as well. Whereas if you go into a colleague, a trusted mentor or trusted colleague who was around but not part of the action, you don't have to explain to them what happened. That they already know. And they kind of know probably a bit how it feels for you. And so we do a lot of peer support type work. And if that's not sufficient, then there are professional supports available through the hospital, or through our professional societies, through ANZICS or the College of Intensive Care, or through the AMA or similar. Or people just go and see their GP if they need to. I think for the most part, we sort of rely on each other a lot. And I think that's similar to many professional workforces. I think paramedics do it, the police do it, armed forces do it, fireys do it. A lot of different groups who have this kind of emotional overlay to their work. The person they're first going to turn to is their colleagues at work.
Okay, yeah, good. I have one more question, which kind of is taking a different tack, but we may come back following this question. Stephen may have some other questions from other guests here, but one final question for me is about the resources that you have available to you. Is it your role within ICU to lobby governments to get adequate resources?
So we certainly have a responsibility to do that. We have a responsibility to care for individual patients, but also to care for patients throughout society. Mm-hmm. So as an intensive care specialist, my primary responsibility is to my own unit and the patients within it. But certainly in my roles as with the Australian and New Zealand Intensive Care Society, I've got a role to advocate for critically ill patients in Australia and New Zealand, and to ensure that we have good matching of resources and personnel to the demand at a jurisdictional level. So we do have conversations, occasionally robust, with the departments of health and with healthcare organisations. And and mostly those they're very respectful. We tend to get a good hearing. Certainly, I mean, there's been a range of terrible things about COVID, but one thing is people have been listening to us. Mm. And I have to give credit to in Victoria, where I live and work, but also I think in most Australian jurisdictions and at a Commonwealth federal level, it's easy to criticise governments. It's an Australian national sport to have a go at whoever's in power. And I have to say, we haven't got everything right, but we've got most things right. And it's easy to pick up things that could have been done better in retrospect, sure. It's easy to kind of observe that things might have been managed earlier or differently. But I have to give credit to the health officers, the Chief Medical Officer of Australia, the Chief Medical Officers of each state and territory. They'll have the occasional misspeak, or they'll get some of the communication might be slightly kind of confusing, but 95% of the time they're actually really good. Mm-hmm. And I think as a committee we'll pick up the 5% that's a bit confusing or a bit wrong, or they didn't quite make it clear. They've done a good job, as have departments of health and premiers, Australian premiers, chief ministers, and cabinet and the Prime Minister. Again, did everything go perfectly? No, of course not. No one would suggest that. but any other country in the world would love to have the problems that we've had. And look, shutting down the economy, what an extraordinary decision to have to make. And to know that it will almost without doubt put Australia into recession, and that it will cause incredible challenges to regular people across the whole spectrum of the community, and cause a huge amount of suffering and heartache. I mean, there's a lot of unmeasured COVID-related harm that is not COVID-related directly, but people losing jobs, their businesses suffering, getting behind on their mortgages. You know, there's huge challenges for people. So I think it's important to give credit to government that when ANZICS and others like us stepped up and said, if you want to save lives, this is what you have to do, they said okay. And they did what they needed to do. And I think history will show that they did a pretty good job.
Yeah, I think you're right. And I think perhaps that strong decision making that's come from the top has impacted society as a whole, and may have I guess led to the compliance, I guess, by the Australian people to do what's has evidently been the right thing. I'm gonna leave my questions there. Thank you very much for answering my questions, Dr. Stephen. That's been fantastic. I will hand back over to Stephen though, because I do think that there may be a few more questions from the floor.
Yes. This Stephen? Yes.
Yes.
Cool. Okay.
Sorry. We needed another name for you tonight.
I mean, to be fair, he has the best type of spelling for Stephen, so we're on the right track there.
Yes.
Absolutely. Brilliant. So one question's popped up, and I mean, you made a really good point around the way that the emotional support works in peer support. That's a really important point. One question that's come up is around, is there a very high burnout rate for staff, particularly newer staff, working in intensive care?
So it's always a risk, and we work very hard to mitigate it. So I think intensive care tends to attract people that have a certain degree of resilience, because you wouldn't subject yourself to 16 years of training unless you were pretty committed. And also people, one of the strengths of our training programs is people have to, when they're junior doctors, have to kind of try before you buy a whole range of different things. So as an intern, I had to do some surgery, I had to do general medicine, I had to do pediatrics, I had to do emergency medicine, I had to do some anesthesia. So you really get to experience a great deal of different things, and you kind of figure out, what is it that I like to do? What excites me? What am I passionate about? And also, what am I kind of good at? I might be passionate about neurosurgery, but if I can't cut straight, not going to be for me. And so people are usually pretty sensible with making choices that, if you love sleeping 10 hours every night without interruptions, don't do intensive care. It will be miserable. If you were really going to struggle with complex decision making, then probably intensive care isn't your sort of thing. And you would kind of get that sense of it relatively early on during a rotation and think, I'll do something else instead. And medicine's a very broad church. People find their happy place, and the satisfaction rate in most specialties is actually very high. It's because people are there because they really want to be there. And so that means that we've got people that are very committed to their professional vocation and are very supportive of one another. So burnout does happen, and it's always a risk, but it's not as common as might be expected given the nature of the work.
No, that's brilliant. And that's actually really interesting as well. The fact that, I guess, by people having a bit of exposure to that, they start figuring out where their interests might be. And I guess that's actually probably really interesting, because I guess a lot of professions probably wouldn't have that either, where it's just a case of you can go and study for something for a couple of years and then within a few weeks realize, oh, I don't like anything about this.
Well, I did my elective in Samoa doing obstetrics, and I delivered like heaps of babies, and I loved it. It was wonderful. And I came back pretty much knowing I didn't want to be an obstetrician. It's not that I didn't enjoy it, but I realized actually by doing that, It was great delivering all those babies, and it was a really special memory. But I also sort of thought, but it's not what I do with the rest of my professional life. So you get to learn what you do want to do, and also maybe what you don't want to do as a junior person.
Absolutely, brilliant. I know we've just touched on 9 o'clock, so we do have one or two more questions, unless you're a bit pressed for time.
I can hang around for a few more minutes.
Absolutely. So we have another question, which is around the ethical standards. And so particularly with bodies like ANZICS, do you find that there are the same ethical standards that are present within both Australia and New Zealand at that international level, or is there a bit of a variation at that sort of thing?
So the ethical paradigm is pretty much well understood around the world. It might be interpreted and applied differently, but the principles are very well established. And one of the unique characteristics about intensive care in Australia and New Zealand is we have a single common training pathway, which is unusual for the world. So every person who works as an intensive care specialist in Australia and New Zealand has come through a pathway where they might come from emergency medicine or internal medicine like I did, or through anaesthesia, but then they go through a comprehensive additional training program that's additional to their original specialty. So this is specialists who then go on to further specialisation. And it's a really great way to ensure that there are the same standards. So I can walk into any intensive care unit in Australia and New Zealand, and they'll all be a bit different. I mean, no two units are exactly the same. The culture will be a little bit different, but I'll totally get it. I'll recognise what I'm seeing. There won't be anything that I think, what the hell is that? Like it'll think, oh, it's a bit different to how I'm used to it, but I kind of get it. I can see why you're doing it, and it makes sense to me. It wouldn't be jarring. So it's pretty similar. I'm not saying the same, but pretty similar, and the fundamentals would be very much the same.
Absolutely, no, that makes a lot of sense, and that's really interesting to know as well. And I guess that is just part of the close relationship between Australia and New Zealand there as well.
Yeah.
So.
Yep, absolutely.
Brilliant. And one more question, I guess this was coming back to something we talked about earlier with regards to specifically COVID-19 and the fact that this is placing a very unique constraint on resources in Australia for a developed country for us with this sort of thing. Do you find that there's a difference in your decision-making priorities as the director of intensive care as opposed to as an individual clinician? Or is it very much the same story both ways?
So in my professional life, I've got a few roles. Some days or some weeks I'll turn up and I'm an intensive care doctor like any of my colleagues, and I'm looking after patients the same way as any other intensive care doctor. And my responsibility is those patients in front of me. And I have to have a mind to what else is going on, but really my patients, I might have 10 or 12 patients. They're my patients. That's how I'm advocating for. That's my job. Other days in my director role, I've got to make sure the entire unit is working, that we have enough medications available, that we've got enough staffing on the roster, that we've got, it's all the big picture stuff, that we've got enough, that we've got timely admissions, that we're not making people delayed, or that if I get a call from a colleague interstate, they want to send down a critically ill patient needing a liver transplant, that I can accommodate them. So then I've got a responsibility, not so much to an individual patient, but I've got a responsibility to 30 patients in my unit and maybe 10 other people around Victoria, Tasmania and South Australia who might need the specialist services of my RCU. Or in my ANZICS role, I've got a responsibility to patients in Australia and New Zealand who are critically ill. So it just works in different layers depending on what my role is in a given day or week.
Absolutely, no, that's great. And it's really interesting because it sounds like at the same time, all those things still kind of come together under the same view of everything in the same umbrella.
Yeah, most certainly.
Absolutely. So look, I think we're done with questions, and we have hit 9:05, so we've done pretty well on time. So look, I will say thank you very much for your time tonight. It's been great having you here. It's been fantastic having you here, and also all of the people who've come to us tonight, both the members of the Rotary E-Club of Melbourne and everyone who's come to visit as well. So it's fantastic. Thank you very much for everyone for attending. Thank you very much for your questions. Thank you very much to Belinda for being the interviewer for this. And also thank you very much to Gabe and to Angelica as well, who organised this event. So look, thank you very much to everyone who's attended. We will have, we will be hanging on from the end of this. We will be terminating our Facebook Live session at the end of this, but we will open up our meeting if anyone wants to stay around and have a chat. Dr. Stephen, of course, that applies to you as well, but I'm guessing you have your mother-in-law as well. So, You have the important priorities to balance.
I better see what she wants. I'll be in big trouble.
Absolutely. So look, thank you very much to everyone. Just as one last thing, I will put out into the chat the email address. So if anyone has any feedback, then they can just send an email off to that address if they have any feedback. If they want to say, good job, everyone. If they want to say, you really could have done better on the streaming quality or something. Like, I mean, any feedback is great. We definitely appreciate this. So for that, we'll wrap up the evening. Thank you very much again, Dr. Stephen Warrillow, for coming to us tonight and for your fantastic presentation. And we'll see everyone soon. Thank you very much.
You're most welcome. Thank you for having me. Take care.
Thank you.
Thanks.